Hi, everyone, and welcome to another edition of Mojo Rising, How to Make Cancer Suck Less with Julie Stevens. And I am joined today with an all-star cast of people I can't wait for you to get to know. Of course, I'm joined by Oscar Sierra. Oscar, do you want to say hi really quickly?
Hi, really quickly.
Oh, perfect. But I also am joined today by the man who is responsible for the actual treatment of my cancer. You guys haven't met him yet, but his name is Dr. Reddy. So Dr. Reddy, would you like to share a little bit about yourself?
So my name is Sreekanth Reddy. I also go by Kanthi. I am a practicing medical oncologist. I've been in the metro Atlanta area for about 20 years. I have been working with Julie recently, have also been working with Oscar Sierra, and I'm excited to kind of join the podcast and let you guys know a little bit about what I know and hopefully just help people understand their disease and get off on a journey to get a good outcome.
And we can't thank you enough for that. And I have to say, one of the reasons why I really love working with Dr. Reddy is because he's a man who is not afraid to really be his own person. He is a true maverick. So when you hear about the podcast and in my book, why I selected this oncologist, you will understand exactly why I selected him as we go through the podcast today, because you're going to hear just some of the wisdom and knowledge he's going to bestow on us. So we are truly so happy to have you with us, Dr. Reddy. Okay, and then our fourth guest is going to be Katy Mathes. So Katy, would you like to do a quick introduction as well?
Sure. My name is Katy, and I live just outside Boulder, Colorado. I am an elementary art teacher of 16 years, and otherwise I'm a mom and have a business, and I'm also part of MOJO Health.
Well, we can't thank you enough for joining us today. And so I'm going to start with my first question with you, Katy, and I actually want you to tell a little bit of your story and why this is so important. But before we get going in that, for everyone on the line, we are going to be discussing today gene expression. So we'll get into all the details around that, but this is all about if you have a particular gene, what does that mean for how you need to behave and what your actions need to be? So as we think about this, Katy, can you tell a little bit about why being a data G is important to you?
Sure. Being a data G or a data gatherer is really important to me because my personal journey with my BRCA2 diagnosis and treatment was heavily defined by a significant lack of data. And I used the data I had to make life-altering decisions that were fear-based and also that really changed my quality of life.
I just want to rip the Band-Aid off. So can you tell us a little bit more? Can you actually tell us your story, Katy?
Sure. Yes. So in 2015, myself and 6 of my family members found out that we had tested positive for a BRCA2 variant that was said to be a high risk for cancer. And we got the reports and they were all really well designed with a big red banner. It was designed to create alarm, and I was alarmed seeing it. The big plus sign, and then it gave all of these different percentages. So the data was presented in percentages, and it said that I had an 84% chance of developing breast cancer. I went to a genetic counselor, and I was counseled over the options, and then I was counseled to get the surgeries. I got the surgeries to remove my breasts, ovaries, and fallopian tubes. And then in 2019, in a wicked twist of the story, I received a piece of mail from Myriad Labs that was basically a form letter. It was very sterile. It was not similar to our first report at all. It told me that they had reclassified my gene, my mutation, and it was now a VUS, which is a variant of uncertain significance, and that I shouldn't base any health decisions on it. So basically, the letter was informing me that the data from 2015 was no longer, it no longer existed. There were no percentages given in the form letter. It was just a letter saying that it's no longer something I should base health decisions on. And it was a VUS. And I went from 84% chance to no percentages at all. So basically, I did not need to have the surgeries that completely upended my life.
How many surgeries did you end up having?
The original mastectomy, the reconstruction, and then the oophorectomy, which is the ovaries and fallopian tubes. But then my sister and I, because she also had the surgeries the same as myself, we had many reconstructive surgeries to, there were just things that were messed up. We kept having issues. So it was a very long and difficult recovery. I couldn't exercise for over 9 months. I'm still recovering, honestly. I went to physical therapy today and was still working on my neck and shoulders and pulling my shoulders back and down. Everything's very tight from after the surgery being like this and not really being able to move. I literally, at the end, when I should have been recovered, I had my arm in a sling and they were sending me to work and saying, you can go to work, but you can't walk even for exercise. Do not move your arm. If it splits open again, we have to redo everything. So I was not able to do anything.
Katy, I can't even imagine, first off, getting the letter with the red alarming, making those life-altering decisions. And we'll come back to the impact on your family and mental health and all that fun stuff in just a second. But then getting the second letter that basically said all of that was for naught. Like, I can't imagine truly how that ripped apart your vision of self from the inside out. So first off, I apologize. And again, this is one of the reasons why Katy is so active in MOJO Health, because she understands the value of data. But when you reflect back on that, like, what else can you tell us about how that felt or what you thought?
Well, looking back, I really felt outside of everything. Like I had no power and I was completely reliant on the genetic counselor. I was reliant on my breast surgeon. I was reliant on Myriad Labs. They were the gold standard for those type of reports, and they actually had a monopoly on it for the longest time. So they were like the biggest name out there for BRCA testing. And so what I wish I would have had was more support to understand that there were different ways to gather data and any kind of support around that.
So
Katy,
go ahead.
Katy, I was just wanted to ask you if you could give us some background on why the family members were tested and what the family history was that led to the finding or the testing for the BRCA mutation.
Sure. So I asked for a mammogram because I hadn't had one. I turned 35 and said, should I get a mammogram? And they asked about my family history. My mother is a breast cancer survivor. And so she had breast cancer, and my great grandmother died of breast cancer. I don't know exactly what age, but it was earlier rather than later. But we don't have any Jewish descent. And at that time, that was kind of my understanding around it. So I don't know why my doctor felt inclined to send me for testing. But ironically, the other family members were also getting tested at the same time. Like, I knew I was getting tested. And then my mom was like, oh, Aunt Carol got tested and she just was positive. So, and then my sister was getting tested. My mom was getting tested and my aunts were all getting tested. And so I don't know what drove that, whether it was Myriad being such a, like, here that everyone needs to get tested, or if they saw something in my family history that was very remarkable, other than having a parent who had breast cancer and a maternal great grandmother, sorry.
How old was your mom when she was diagnosed?
I think she was early 50s. I should already know this, but I don't have that in front of me. I'd have to text Jane and ask her.
I think that's adequate. And then any other family members with cancer in your direct lineage?
Nope.
No.
Not with breast cancer. My maternal grandmother died of throat cancer. My maternal grandfather died of lung cancer. But I don't even think my doctor asked about those things. She just asked about the breast cancer history.
Okay. And what type of provider suggested that you have BRCA testing? Was it your primary care doctor? Did you see an oncologist? Did you see a breast surgeon?
That was my primary care provider when I asked if I should get a mammogram.
Okay.
She brought it up. Yeah.
Okay. Thanks for the background. I mean, I think that helps us put things into perspective.
And Katy, when you got the letter, like what was, obviously you didn't go back to your primary care physician to make these decisions. So who did you actually talk to?
I went to a genetic counselor. Let's see. The genetic counselor was in the Denver area. And I remember her saying, like, being in the meeting, my son Jackson, who's now 9, he was about 1.5. And during the meeting, when she was revealing that I'm positive for this mutation and here are all the percentages, at one point she said, many people, when they find out they have this gene, decide not to have more children. And that was a very big sign to me that, like, wow, this is so bad that I shouldn't want to pass it on to a child. And she went on to talk about other options. One of them was like, it wasn't in vitro. It was something else. I forget what it was called, but whatever it was, I was like, well, that sounds like a $30,000 option. And she's like, yes, it is quite expensive. And I said, well, then that's not an option for me. And that essentially closed the door on me having another child. I had literally been every single day at work with one of my coworkers who also only had an only child. And we had kids the same age. We every day were like, should we have another? Like 1 versus 2 was like the conversation of that entire school year. And her saying that really closed the door on that whole idea for me.
So let's talk a little bit about what this did to you. So what did this actually do to your body?
Well, I am pretty mangled. I have a lot of scars and I don't have a lot of upper body strength from lack of being able to exercise after the recovery. And then just like I said, I'm still in physical therapy now, trying to figure things out. So that was definitely a big thing. I'm not really, like, my body image was impacted significantly. Like, I don't really feel like my body is my own. Like, I feel like I have like parts of me that don't belong, and just it feels very weird. I also entered menopause in my mid-30s, which has been awful. I spend hundreds of dollars a month on different hormone replacement therapy medications. Like, I have to get special compounds because the one-size-fits-all approach didn't work for me. So I spent a lot of money on that and tons of supplements. Julie and I have compared how many pills we each take a day, and she has cancer, so it makes sense for her to take so many. But I am I'm a rival almost. I take really a lot of different supplements. And then obviously I lost my ability to have more children. And so my son doesn't have a sibling. So that's kind of a major part of it.
Yeah. Now, you're obviously showing some emotion right here. So this did more than just your physical health. I know from many years of friendship that this actually impacted your mental health quite a bit as well. So can you share a little bit about what this was like from a mental health perspective?
I handled everything very, very well because I was relying on the data I was given, and I really believed in the data. And so I felt like I was doing the right thing. And then, when the data changed, or when I found out that they should have never put out that report. They didn't have enough data to put out that report, in my opinion, and you might agree. When that changed, I had a really difficult time just dealing with the whole fact that I had just gone through so much and it was for nothing. Like, when I was going through that, my son was 1.5 and 2 years old. So he had to learn how to climb into the car on his own and get into the car seat because I couldn't pick him up. And he didn't understand why he couldn't give me a hug. So there's just a lot of trauma from like those are times I can't get back. I can't get it back.
For sure. Oh, Katy, my heart's ripping out for you. So take just a minute and take a deep breath, because I know that this is a lot to share, and it's a lot to share with our listeners as well. The next question is kind of the change, and it's the turn. And if you had the opportunity to do this over again, what is the data that you wish you would have known to drive into this decision?
Well, I wish I would have been given more guidance that I had no understanding that this data could possibly change. I was counseled to do the surgeries like quickly. They were like, you have such a high risk. Like I literally asked the genetic counselor at the end, like, well, what would you do? And she said, I'd get the surgeries. And I said, okay. My mom's a pharmacist. I trust in medicine, and I trusted this genetic counselor. And when I went in and saw my breast surgeon, she got the report and she knew, she's seen this before and commended me for doing, being brave and doing the right thing. And I wish I would have known that the data could change. I also wished that, there was the options that were given were really dramatic. It was, well, not all of them are dramatic, I guess. Like one of them was, I think they gave 3 options for treatment. One was increased screening. So basically just get more mammograms and MRIs. And that didn't seem like enough based on like how much fear was caused from this report. The second one was taking chemotherapy drugs like tamoxifen, which I didn't understand. And my mom took that when she had cancer. So I was like, how would that be a preventative strategy? And why would I do that? And then the third one was the risk reducing surgeries. There was nothing in there about, epigenetics, which doesn't make any sense to me. There was nothing in there about what's your environment like, what are you eating, or what are your habits? There were no questions like that, or no suggestion or conversation that it could be handled in any other way besides more screening, chemo drugs, or risk reducing surgery.
And I'm reading this right now off of cancer.gov. So this is directly off of a well-known website. And it says here that breast cancer, about 13% of the women in the general population will develop breast cancer sometime in their lives. But by contrast, 55 to 72% of women will inherit a harmful BRCA1, or 45 to 69% of women who inherit a harmful BRCA2 will develop breast cancer by the age of 70 to 80 years. So that does make me wonder, if you had this all to do again, Katy, and you think about the chance of knowing what could be versus what is versus what was, would you have made the same decision, or what decision would you have made?
Well, knowing what I know now, I would have made a different decision. Of course, my data has changed. But first, if I was talking to somebody who was going through this right now and they had just gotten a report, I would say, ask your doctor about epigenetics. Epi means it means above genetics. So it means that just because you have a gene doesn't mean that you're going to express it. So whether or not you express it depends on a lot of other things like your environment and your behavior. And nobody told me that. That was not even talked about. And to my knowledge, epigenetics has been studied since like the 70s. And I think it was discovered in like 1940 something. I don't know a ton about it. I just know that it should be part of the conversation. From my point of view, genetic counselors should be talking about the fact that just because you have a gene doesn't mean you're going to express it. And there are other ways to mitigate.
Yeah, absolutely. All right. Well, Katy, thank you for sharing your story. And I know how much it's meant to you and to your family and to everyone who knows you. So I appreciate you sharing that with our listeners. Now let's flip over to ask a couple questions to Oscar and Kanti to understand a little bit more about the medical side of this story. And so my first question for you guys is, certainly we've talked a little bit about BRCA1 and BRCA2 so far today, but what are some of the other genes that would cause people to consider to act that may not be BRCA?
We're just scratching the surface on all this stuff. So there's a lot of genes. BRCA1, BRCA2 is one of. So if you divide, I like to divide everything in like yin and yang, right? And like into two. So if you divide these genes up into two major categories, you have tumor suppressor genes. That implies that they are there to help you not have tumors. And then the other category, if you're looking at it under this kind of conventional genomic lens, are oncogenes. So these are genes that might be associated with having tumors. So if BRCA in this scenario is a tumor suppressor gene. So if you have a mess up of some sort, a mutation in the thing that is supposed to prevent you from having cancer, among many other things. I mean, this gene codes for a number of proteins and has several downstream consequences. But among them is, yes, protecting your genetic code from having mutations, which is the initiation process of cancer. I would say that this is, generally speaking, maybe 8% of what's going to determine your health, as per Dr. Russ Jaffe, MD, PhD, a good friend of ours. And as Katy said, that's a portion of what is important to look at as far as gathering data. And it's maybe 8% at most, generally speaking, unless we're talking about like a sickle cell anemia or something like that. But, I would be looking at other things with more scrutiny, your diet, your lifestyle, what you're putting in your body, what your body environment is in. Are you on a tarmac, inhaling jet fumes all day long or what? So anyway, I don't know if I answered your question, but there's a lot of genes. We're scratching the surface. And this is a relatively small portion of what's actually going to determine overall survival and quality of life.
Dr. Reddy, anything you'd add to that question? And the question was, what genes would cause people to act today?
So, if you look at the data out there that we have, understanding that this is all relatively new, well, that's the unfortunate consequence, is that people are acting on new data without having all the information. That's, unfortunate. Katy, thank you for sharing your story, because I think that's so important that people are making decisions on new information without really waiting to understand the full story. If you look at the various genetic panels that are out there in the data, there's probably several hundred genes that have been identified, not all of which are tested for, that are associated with increased risk for developing cancer. The story that Katy tells us is that the level of sophistication and understanding of the genes that were on the specific panel that she had was not accurate at the time. And the data later came out that specific mutation that was present in her and her family members was not something that likely increased risk as much as was thought. And so I think this takes us back to the way of thinking, which is that, you really needed to get the story of the family, the rates of cancer, the ages at which they developed cancer, and meld that in with the recommendations. So, if you look at somebody like Katy, she had this mutation. Yes, at that time, it was thought that she had this BRCA mutation and that there may be increased risk of developing cancer, but she was 35 years old. She had a first-degree relative, being her mom, who developed cancer in her 50s. The likelihood of her developing cancer within the next 5 to 10 years was still relatively low, even if she had BRCA. And, with adequate monitoring, keeping an eye on things, you could have kind of kicked the can down the road. You could have considered having a child. Let's just see what happens. Let's follow you closely. Now, obviously, part of the issue here then becomes once you have seen this result, when you see that genetic result and you've talked to these genetic counselors and other physicians, all of whom I have respect for, you have this burden in your mind where you've been told you have an 84% risk of developing cancer. Well, interpreting that as an individual, that basically tells somebody that, you're going to develop cancer. So now you're 35 years old, you have a young child, you have a job, you have a family, and you've now been told that you have 100% without anybody really telling you that if you look at the general population, what is the risk of them developing some type of cancer over time? It's probably 50 to 100%. The reality for you is nothing's going to happen. It's not likely to happen anytime soon. Let's just take a deep breath. Let's understand this more. There's more data coming out every 6 months. Every month is the reality of this. Maybe we should repeat this analysis with a different lab, because there's more than one way to skin a cat, and there's more than one way to analyze genes, and really kind of take a step back. Let's get more information. It's going to take time to get that information. We understand that we've placed a huge burden on you, but we don't need to make any decisions now. So I think the genetic information is important, but I think it's also incredibly important for people to understand that what we know to do from this genetic information is not nearly as mature as people have led the patients to believe. And so I like the information, but I would say that when people talk about it, they really need to be very cautious before doing the test and after doing the test. And that's really the big takeaway point that I would like people to understand.
So you've mentioned something a few times. Well, let me take a quick break to say, now you just heard why he's my oncologist, because the examples he just gave were extremely rational, thought-provoking, gave you a lot of things to think about. So now you understand why Dr. Reddy is the guy that I go to for all my answers. But you mentioned something a couple times, and it was about the timeliness. And so when my gastro woke me up from my colonoscopy and he said, you have cancer, I think you have cancer. And I said, like, real cancer, not real cancer, tell me more. And he said, I can't get the infant size camera around. And I was like, okay, so it's real cancer. And I said, how long has that been growing? And he said, probably 10 years. And that freaked me out because I've had cancer growing in my body for 10 years and I had no idea. But also I'd had it growing for 10 years and I had no idea. So my question is, how long does the typical cancer take? Like, if you were to get this in the mail, is this something that I need to make decisions in the next 24 hours or next week? Or like, what would be your timeline around actually trying to drive to a decision?
I think that with genetic mutations with cancer, the timeline is really over the course of months to years. It's not, we need to do this right now. And I really wish, in hindsight, that everyone, the genetics counselors, the surgeons, the medical oncologists, the general practitioners understood that this is just part of the picture, like Oscar had mentioned. And so you have time to make a decision. You have time to improve those statistics with examination of all these epigenetic factors, just like you said. And so you have time. These cancers don't develop overnight. They develop over the course of long periods of time.
For sure. Are there any specific genes that you guys are aware about where someone would need to move faster than others? Or are all these pretty much the same where you would say, like, let's go ahead and measure twice before we cut?
I'm not aware of any germline genetic mutation where there would be an urgency.
Ask for anything from your side?
No, and let's help people understand what germline mutations are. So germline mutations are, things that you're born with, right? That are in your germline and your mom and dad. So, being born with blue eyes or has to do with your genetics, as opposed to the genomics associated with a cancer once it's been identified and biopsied, and you get to see, you might have blue eyes, but the cancer has brown eyes. And so that's genomics. And that's, I think you said we're going to talk about that at some later date. So we're focusing on germline stuff. And with regards to specifically cancer, BRCA, right, is this tumor suppressor gene. And, we make cancer accidents all the time as we replicate our cells, but our system, including our immune system, has these checks and balances to make sure that these things don't kind of start replicating more and more. And one of those many checks and balances is mediated through this BRCA1, BRCA2 pathway. The way I explain it to patients here at my clinic when they ask about, oh, well, I have a BRCA mutation, or, should I test for that? Yes or no? And I'm like him. I'd say more data, more better. But let's kind of take this with a grain of salt. So if we understand one of several jobs of BRCA, I equate it to hero units. So here in Atlanta, we have 285. It's a big circle of traffic that rolls around Atlanta over and over again. And we have these cars. They're not cars, they're trucks. They're emergency vehicles run by probably GDOT, Georgia Department of Transportation, that, there's X amount of them, let's just say 10 of them, driving around 285 in a circle all day long, all night long. And why? Because you can expect that with 6 million people in Atlanta and, 50,000 of them on 285 at any given point, someone's going to have a flat tire, which is just a good bet. So these hero units are not ever too far away from someone that runs out of gas or has a flat tire. So I equate these to BRCA, right? And so someone with a BRCA mutation, instead of having the normal 10 hero units, maybe has 5 or maybe has 3. So if someone has a mutation happen, or flat tire, in this case, the BRCA unit can kind of help them out and fix the tire and get back on the road. So the BRCA kind of addresses these accidental mutations that could lead to cancer. And so by having proper functioning of the BRCA mutations of these hero units, that stands for, I think, highway emergency response. I don't know what the hell it stands for, but something like that. And so if, you just have fewer of these running around, but, okay. So, well, what's on your road? If you're putting a bunch of tacks and, glass on the road, you're more likely to have a flat tire. But if you drive a Hummer and you've got really massive sturdy wheels that it takes, a lot to puncture these things, then whether you have 3 hero units running around 285 or 10 or 20, it's kind of a moot point. It doesn't really affect your outcomes that much as far as getting a flat tire. Now, you may have other issues as far as cost of gasoline, but you see what I'm saying? So there's all these other factors as far as like, well, did you check your gas before getting on 285? Did you check your tires? Do you throw bottles of glass everywhere? Does, in this case, your oxidative diet and lifestyle, like if you are that person on the tarmac, right, with the flashlight thingies, you're exposed to a lot of oxidative damage, and oxidative damage does cause mutations in your DNA, which then could lead to cancer. So, if I was one of these guys on the tarmac and got that test done and I was positive, I would say, well, let's not have this job and maybe have another job, because I'm already at a high risk because of inhaling a lot of jet fuel, but I'm at a even more compounded risk because of the BRCA mutation. Of course, you could also take antioxidants, and that's maybe a whole other story. But my point is that there's chemical, pharmaceutical options, there's surgical options, there's wait and see options, there's botanical options, there's nutraceutical options, there's lifestyle, like change your job. And I mentioned the tarmac thing because there's actually research on those guys and their level of oxidative damage as per 8-hydroxy-2-deoxyguanosine, 8-OHDG, average is like 20. And it should be below 6. Now, there's good research that if your oxidative damage to your DNA is higher, there's more cancer. That's just kind of a no-brainer, because if there's more tacks and glass on the road, you're going to get more flat tires. That's kind of easy to figure out. So then, what it should be under 6 or 5. So can we being a data gatherer, can we measure oxidative damage? Can we measure our propensity to get damage from oxidative damage? The answer is yes and yes. And there's not one marker. There's genetic markers. There's environment. You can measure your air. You can measure your blood for the gasoline that came from the air or your urine. You can measure, your myeloperoxidase, all kinds of oxidative stress markers and your propensity to have damage from those markers in the case of BRCA. And so I would advise if someone had a BRCA1 and or maybe BRCA2 mutation and say, you could go do surgically and irreparable damage to your body, or you could wait and see, or you could take this horrible drug tamoxifen, or you could look at your diet and lifestyle and measure, not just hope and pray, but you could get a baseline status of oxidative damage, and then you can change some stuff, and then you can measure again and use data to guide, and I've met patients that said, well, I don't think I'm likely to change my diet and lifestyle. I really like this, tarmac gig, in which case I would support them and say, well, great, let's look at surgical and chemical options. And it's just, whatever you want to do, man or woman.
Okay, so let me ask you a question on that because, and tell me if I'm right or wrong, and feel free to tell me I'm wrong. So obviously looking at something like a mammogram would be a great opportunity to measure what the score is, but it's not measuring how well the players are doing. So I would think about, could we look at different things like blood markers, for example, for colon cancer, CEA or CA19-9, and would an example of an opportunity be to start to measure different blood markers that could be presented if you had breast cancer or had ovarian cancer, et cetera, and use that as an indicator of how frequently you needed a mammogram, since mammograms do have some toxicity associated. What about, is that an option D that wasn't explored at all?
Yeah. And I don't think it's enough to still hang a hat on, because you could still have ovarian or breast or prostate, all of which are associated with BRCA mutations. I think pancreatic as well, if I'm not mistaken, Doc. Yeah. You have an increase, so you can check for the pancreatic and breast and prostate cancer markers maybe a little bit more often than your average Joe or Jane. And you can measure the oxidative stress markers that frankly are high in all Americans, but are high, could be higher because you have this job where you inhale jet fuel all day long, right? Or you sit next to a printer, which spews out oxidative damage gases, or you name it. The world will easily kill you if you look hard enough, right?
For sure. Dr. Reddy, would you add anything to that?
Yeah, I mean, I think that's a very good descriptor of what's happening out there. I would add things like, if you look at bilateral mastectomy in BRCA2 patients, and you're counseling a patient, well, the black and white way to discuss it is that high risk of developing breast cancer. We know that there's a risk reduction by doing bilateral mastectomy, so we recommend bilateral mastectomy for these patients. The reality is that it shouldn't be recommended, it should be discussed, but it should be discussed as part of an overall strategy. And I think what's missing out there is the overall strategy that Oscar so eloquently talked about. If I asked a room of physicians and I said to them, does bilateral mastectomy in patients with BRCA2 mutation, and not the variant of uncertain significance that Katy had, but the well-defined BRCA2 mutation, does doing a bilateral mastectomy improve their survival? Well, there's no data for that.
Right.
We still don't have data. We do have data that bilateral salpingo-oophorectomy in patients with BRCA2 improves survival. We certainly don't have data that it needs to be done at the age of 35 in a woman who's considering having another child. But it's much easier to say, we recommend this, and then can you see my scheduler? And that's the problem here, is that nobody really took the time with Katy with the information that they had, and I think it's very unfortunate that the information regarding this variant of uncertain significance changed over time. I think that Katy should have been made aware that that is possible, but all these things should have been discussed. What is the outcome going to be? What is your expectation of what life will be like after the mastectomy? What is the reality of the benefit? What is the time frame at which all these things need to be done? It didn't need to be done in 3 months. We know that for a fact. 6 months, 1 year, 2 years, 5 years, not doing it at all and monitoring things, waiting for new data to come out. We have used tumor markers for years. Over the past 2 or 3 years, we have the availability of circulating tumor cells to really help somebody to some specificity. You may or may not have active disease right now. I think that's useful. But again, these are all very new things and we don't know how to use them. But I like all this new information. I don't want to sound, and I don't want to speak for Oscar, but I think Oscar wants to get as much information as possible and then put that into context. And that's really the most important thing that I would like patients to understand, is that there's a lot of information out there. There's a lot of noise and there are a lot of choices, and really explore all your choices and get as much information as possible.
He just told you to be a data G, friend. Let's just be clear. He just said to be a data G. Sorry, I didn't mean to interrupt you.
Be a data G. Make sure that someone takes the time to work with you to understand the data and take your time in making decisions.
All right. So let's think about this, Dr. Reddy. If you were to counsel your spouse or your sibling or your mother in what to do if they had a BRCA, what would you say if they had a BRCA2 mutation?
I would want to look at the whole picture. I think the family history is very important. Katy's family history was of having a mom with breast cancer in her 50s. I would tell Katy that in all likelihood, even if you were to develop a breast cancer, the risk probably is higher after the age of 40, probably more like 45. And I don't have, obviously, the information regarding the specific histology and type of breast cancer that Katy's mom had, but that would be very important. How aggressive was her breast cancer? Was it an estrogen receptor sensitive breast cancer? All these things were important. Nobody looked at the lineage in the family to really show that this family was behaving as what we classically think of as a BRCA2 mutated family. And you would need to start thinking like, well, maybe the risk isn't quite what we think it is. Let's just take a pause. Let's make sure that she's had breast MRIs. Let's do a pelvic ultrasound just to take a look at her ovaries. Let's talk to her about lifestyle changes. Let's talk to her about her stressors. Let's talk to her about her diet. And let's revisit these things, because the reality of, if you look in this family, they've done well. And Katy's would have done well. And so that's what we really need to be talking about. I think that we should never be alarmist, because that never serves any purpose. We really need to understand things.
I love that. I love the idea of like, let's take a pause and gather all the data we can and then figure out our strategy. All right, Oscar, what would you add to that? If this was your spouse or sibling or mother, what would you ask? What would you recommend they do?
Yeah, be a data G. Gather the other genetic markers, gather the oxidative stress markers. There are several. I mentioned 8-OHTG. That is a really solid one. It's not very cheap, but it could be urine or blood. Myeloperoxidase is another one. F2 isoprostane is one that's pretty cheap. That's a urine test. Look at their, environmental toxicity is a thing that causes oxidation. So does eating, fried foods. And so look at the diet, look at the lifestyle, look at, as Dr. Reddy said, look at the heritage, the family history, monitor things, get a baseline, do some stuff, and then monitor again, make sure there's less oxidative damage, bathe people in antioxidants. I mean, that's kind of generally a safe bet. You're not going to go wrong eating foods that are red and green and purple and yellow and orange. And these things are chock full of antioxidants, and they do stabilize free radicals, which cause the damage that can affect the DNA inside the nucleus, right? There's a handful of antioxidants that can cross through the cell membrane into the nuclear membrane, and protect oxidative damage in the DNA, NAC, vitamin C, vitamin E, green tea. I believe the ECGC does this. There's probably a handful of other ones. So, pick one or three and be on it the rest of your life. Worst case scenario, you prevent some other disease. And then, like Dr. Reddy said, okay, what is the end point? The end point that they were talking about with Katy was breast cancer, yes or no, correct? Okay. So I'm not here to minimize breast cancer. It can be a really horrible thing, especially triple negative breast cancer. But statistically speaking, especially for a 34, 35-year-old, it's still relatively rare, right? Breast cancer. And then, so just to kind of play devil's advocate here, so what? So what if someone gets breast cancer? Like Dr. Reddy said, is that going to kill them? Statistically, not. We have a patient that's 87 years old. She's had 7 recurrences of breast cancer, never did chemo, never did radiation, never did a mastectomy, has had a full, long quality, excellent quality of life, and she shrinks it with some herbs and natural stuff, and yes, aromatase inhibitors and drugs, and then does a simple, outpatient type lumpectomy. Bada bing, bada boom. A couple years go by, she gets it again. After the 3rd time, she's like, I know the drill. And her quality of life is great. So, that's kind of your garden variety estrogen receptor positive cancer, as Dr. Reddy said. It kind of matters what type of cancer. If it's a triple negative, that's a different story. But you get as much data as you can, and you do the best you can with what you got, and gather, environment data, host data for the person. And if there is a pathology, then you gather all the data about the pathology and the microterrain in which that pathology is thriving or not thriving. And then and let's talk about who. Okay, who's going to interpret this? Having worked in a hospital, and my office was, when I worked at a cancer center, Atlanta's largest, hospital provider, my office just happened to be next to the genetic counselors. They had no idea what these genetic mutations were. I mentioned, I've got a patient with ApoE mutation. What do you guys think about that? They'd never heard of ApoE, even though it's been associated with cancers. And they didn't know about cardiovascular, the MTHFR, which is come on, at this point, everyone knows about this gene. They had no clue about this. So, and then they had no training whatsoever in identifying these genes. They had no training whatsoever in looking at the dietary and environmental factors that affect these genes, or how to measure oxidative stress, which has to do with some of these genes, not all of them. And so they just have an algorithm as to, how many family members. Was it 7 or 2? Because we draw the line at 5. And then if it's more than 5, then we cut things off. And it's just an algorithm, right?
Well, I think no matter who you're going to seek advice, the whole point we would say is it's not one person's advice you want to seek. You want to seek a couple of different alternative providers, different people. If you're going to a carpenter, they're going to tell you to build the cabinet every single time, and that's the answer. If you're going to a plumber, they're going to tell you to build the toilet every time, and that's the answer. So the whole point is you need to get multiple different perspectives so that you get a round table of different advice. All right. So as we wrap this episode, Katy, I just want to go to you one more time and say thank you so much for sharing your story. And I know it's a tough story to tell, but is there any other advice that you would leave to our listeners if they were diagnosed or were found out to be positive for one of these genes?
Yeah, absolutely. I mean, I had a lot of thoughts going on listening to Dr. Reddy and Oscar. I heard them say that I should have been told that there was going to be new data, and that was something that was definitely not talked about. Finding other labs to give me reports was difficult at the time because Myriad Labs had a monopoly on this type of testing for the first however many years. And so it actually, just recently, maybe in the last year, a different lab has been able to catch up, and now they can classify me as well, VUS, but they couldn't before because Myriad doesn't even share their data. They don't share it at all. So, definitely nowadays, getting tested with other labs could help. But to be honest, Myriad has this private, they have all of this data that they don't share. So they're still going to give you a more updated picture of it. As far as genetic counseling, I feel like the entire field of genetic counseling needs to be evolved because it wasn't just me who was counseled that way. My sister, I was in Colorado. My sister was in New York, and she had the same, Myriad Labs report, and she had a completely different genetic counselor counseled the same way as me. I had an aunt in Texas. I had one in St. Louis and one in Illinois, and my mother was in Illinois, and then their cousin was out here. Everybody saw different genetic counselors. Everyone was counseled to get the surgeries. And that's, the idea of, Dr. Reddy said, never be alarmist. Well, what is the field of genetic counseling and what are they doing exactly? Because it is absolutely alarmist. And the way that they designed my original report, the way that Myriad Labs designed it is alarmist and intended to cause fear. And I think that's a whole other podcast in itself. But if I were talking to a person who just got diagnosed with a BRCA2 or BRCA1 mutation, I would say, talk to other specialists. I'd send them to Oscar and be like, talk to Oscar. You probably need to look at your environment and start gathering data and figuring out how you can prevent it because it is preventable.
Absolutely.
Dr. Reddy, anything else you'd add?
No, and I think that, my heart goes out to Katy, and I really appreciate sharing her story with us because it really opens people's eyes to the pitfalls of the information that they get.
Well, for everyone listening today, certainly the message you've heard loud and clear from all of us on this phone are to be a data G, and data is truly the answer to help us solve all of these challenges and help us have a stronger strategy and figure out how we can heal our bodies. So from all of us at Mojo Rising, How to Make Cancer Suck Less, we appreciate you. Be a data G, and we will certainly look forward to talking to you again soon. Please listen to our next podcast. As Oscar mentioned, it's going to be on genomics and how genomics drove my strategy. So thanks everyone for listening. We so appreciate you, and talk soon.